Miami show. I'm your host, Damien Pardo, and today we're going to be talking about World AIDS Day. But before we start our discussion, if you don't know what Forward Miami is, it's a local nonprofit that specializes in diversity and inclusion, and we are the producers of the Gay Ocho Festival in Little Havana, Miami, Florida. So as we move on to talk about World AIDS Day, I'd love to introduce our guest, which is Dr. Susanne Doblecke-Lewis. Welcome, doctor. How are you?
I'm great. Thank you so much. And thank you so much for having me here today. Really appreciate it.
I World AIDS Day for me, as someone who is gay and grew up here and dealt with the AIDS epidemic my whole life, is really a day with a lot of depth and meaning. And I still wear my little, you can see my pin here, my AIDS ribbon. And I'm wondering, you're looking at the front lines today, and I'm wondering your observations on World AIDS Day about HIV and AIDS.
Yeah. I think, World AIDS Day is a very poignant day, and it's a good day to remember, how far we've come, for one thing, to remember those we've lost over the years. And it's been, many years now since, we're looking at 40 years of the HIV epidemic at this point, and how things are now compared to how they were in 1982, 1983. It's just, there's no comparison. It's a world of difference. And whereas then it was a struggle just to get testing that worked and to have people have a reliable way to get tested, and even then not to have treatment options. Now we have amazing treatment options. Testing, of course, has been widely available, but the treatment options are really astounding. We have the information that undetectable is untransmittable, meaning people who are taking medication for HIV and are suppressed with their viral load, so their medication is working well, don't transmit it to other people. This is really amazing.
So that basically means that if you go ahead and you take a PrEP pill, a special pill, once a day, you can suppress the virus in your system so that you actually won't get it, and you also won't give it to anyone.
Yeah, so we use the medication, we call it antiretroviral medication. So the medication that directly fights the virus, we use it both for treatment and for prevention. So when we're talking about—
I'm sorry, who do you recommend take this? Like, should everyone take PrEP, or is this, how should they know if they should consider this?
So what I tell, our doctors in training and people who are learning about how to give PrEP is, if people think that they could benefit from PrEP, they probably are good candidates for PrEP. So that's a start, right? So if someone feels that they need an extra layer of protection against HIV, that could be because they know that they have partners or partner who is HIV positive and who may not be virally suppressed, or that person is on medication, but they want to have an extra layer of security. That would be a good option. People have multiple partners. And people who've had recent sexually transmitted infections like gonorrhea, chlamydia, syphilis, that's also an indication. Excuse me. That they could benefit from PrEP as well.
And kind of, what do you see on the front lines right now as far as HIV and AIDS?
Sure. So, excuse me, I've got a little bit of a throat thing. I'm just going to get a bit of water. Excuse me.
I'll join you.
So what we see now is, it's a really two worlds. One is, treatment and prevention are really quite available. And a lot of people are benefiting from that and doing well and really thriving. But unfortunately, we're still seeing in our hospitals here in South Florida, people who are not diagnosed early, who don't get tested early in the process, and who still go on to develop all the complications of HIV and AIDS. So we're still seeing that, sadly.
And doctor, what does that population look like? What are some characteristics that kind of are the ones that are showing up undiagnosed?
Right. So people who may not have suspected that they could have been exposed to HIV, there are people who've had, excuse me, only one partner for a long time, for example, and they may not have suspected that that person might have HIV or might even have other partners, for example. Um,
Wow.
we also see people who are recent immigrants who haven't had the opportunity to be tested or haven't been tested, and people who've been living here and just haven't encountered the medical system or haven't had an HIV test in a really long time. One of the things that we do here, one of our programs is focused on getting primary care doctors and doctors of all sorts to do a HIV test as part of the regular lab work that you do for anyone. Because you'd be surprised, honestly, Damien, how many people have gone to their primary care doctor or even the emergency room. They've gone places and they assume that they've had an HIV test because they've had blood work done. And they assume that that was part of the blood work, but oftentimes it isn't. And in my opinion, it really should be.
Is that also part of just the general stigma around HIV and AIDS, which I think a lot of times leads doctors, to assume that this person couldn't possibly have HIV because they don't look LGBTQ or whatever the situation might be?
Yes, stigma unfortunately infiltrates and affects everything that we do. And that's what you say is exactly right. People sometimes they're even concerned that if they bring it up, their patient might be offended or think that the doctor is making assumptions. All of that is, really we're so far beyond that at this point. We know that everyone does better when we just talk about this openly and test everyone, regardless of what we think their risk is, or even honestly what they think their risk is. For HIV, it's the recommendation now that every single, human adult get tested for HIV at least once, regardless of risk.
That's really important. So actually the recommendation is that everyone gets tested for HIV annually, at least.
At least once, and then annually if they have any change in partner, or if anything else comes up that might produce risk, then annually would make a lot of sense. If someone's sexually active with more than one partner, for sure, at least annually, sometimes up to every 3 months. But everybody should be tested at least once. Everybody. Doesn't matter if you're a nun in Omaha, Nebraska, you should be tested for HIV at least once.
Well, I also think that this whole COVID pandemic has really kind of helped us to understand what it must have been like at the beginning of HIV and AIDS, and still continues to this day somewhat, because if you cough in a crowded room, everyone kind of looks at you. And so if someone thinks that you're a part of this community, whether it's LGBTQ or at the beginning Haitian, or anyone that they perceive might have some kind of HIV exposure, they get treated quite differently.
Right. Unfortunately, that can be true, and certainly in the past, there has been a history of stigma and discrimination, and so that influences how people feel about this, and we have to acknowledge that. And I think also kind of actively work past it, right? And I think it's every physician or provider's responsibility to individually work past that with their patient population by being very open, non-stigmatizing, and really trying to look at this from a public health point of view. There really is no role for continuing that stigma or perpetuating what's happened in the past. It's really counterproductive.
And what are some of the programs that you're running right now that have to deal with that?
Sure. So a lot of what we're doing in our programs is around making sure that HIV prevention strategies are available to everyone who could benefit from them, regardless of financial situation, insurance status, immigration status. So we have a clinic here at the University of Miami, the PrEP clinic, and also a mobile PrEP clinic, which is basically the same thing on wheels that goes to 5 different sites around the county.
Wow.
Yeah.
And what do people do if they want that mobile testing unit to come by, by where they are and help out their communities?
Yeah, absolutely. So we love to talk to people who are interested in working with us or interacting with us. And certainly I can give that contact information. The way that we do our mobile clinic, we go to 5 different sites on a rotating basis. So every day we go to one of our sites Monday through Friday. So we go to each site once a week. And that's Miami Gardens, Hialeah, Liberty City, South Beach, and Miami Beach, and Florida City, down in
Wow.
South County. And the reason we do it that way is so that the people in the community know that we're coming on a regular basis. They know, for instance, in Liberty City on Thursdays, we'll be there.
Makes
And
sense.
because prep is something that people need to take and follow up with over time, it's not a one-time deal. We want to make sure that we're returning to the same communities, time after time, and really being there in an expected way so that
Can
we
you
can follow.
can you explain that a little bit for the people that are on prep? What kind of a commitment are we talking about?
Sure. So I always say that there's no commitment, right? So when people start prep, they can always decide to stop it. But we would like for that to be a choice, not just, like forgetting or just kind of letting it slip, but rather like, you can decide to start it, you can decide to stop it also. So there's no long-term commitment. But for folks who start prep, we do blood work at the first visit, make sure everything is good. We follow up every 3 months to do testing and, if needed, treatment for sexually transmitted infections, so gonorrhea, chlamydia, and syphilis. And we also do check blood work, liver function, kidney function, and of course HIV tests. So that's typically every 3 months that we'll see our clients who are continuing on prep. And if someone decides to stop prep, which, a lot of people do have what we call like seasons of risk, right? So there might be a time when it's particularly important for them to have that extra protection from prep. And then things may change. People go into a long-term relationship, or for, they aren't sexually active for a while, or, something comes up, pandemic, right? For some folks.
Is this something like you're going on vacation and you go on prep? I mean, is this I
Typically
mean,
not. Although there are folks who have looked at that kind of thing where you take it for a short period of time, where they're, for instance, on a cruise, where people may know that they're likely to have more risk during that time. So that can occasionally be done, but for the most part, our clients, and the general recommended way that it's done is to take it daily, and then until you get to a point where you feel like it's not something that's beneficial, and then we usually do an HIV test at the end and stop it. There's also other ways to take prep. So there are some strategies that involve taking it just before and just after sex. It's called 2-1-1 dosing. It takes a little bit of discussion with a provider to really understand how to do it right, because it's not just taking a pill before and after sex. It's actually taking it in a certain way with 2 pills ahead, and then follow up on the subsequent days. So that also requires supervision from a physician and HIV testing. So those are some other things that people could discuss with a provider if they're interested, or have a scenario where they don't feel like daily prep is the way to go.
and what about post-exposure?
Yeah, thanks for bringing it up. This post-exposure is really important, and I think a lot of folks don't know about it or don't think about it too much. But post-exposure is when someone who's not on PrEP or not taking it regularly has an encounter where they feel that they might have been exposed to HIV, and then within 72 hours, so within 3 days, and it's very strict. It really has to be in that time frame. They would get an HIV test and start on 3 drugs against HIV with the goal of preventing infection.
Wow, that's very powerful.
And that's taken for a month. So it is very powerful. It's an important thing to know about. We also do offer that through our clinics, as do some other clinics in the county. And I think it's not used as much as, frankly, it should be, right? Because I think a lot of folks have these encounters which can be really stressful, where they feel like, oh, like something happened, I'm really concerned.
Yeah.
And they don't realize there's something they can do proactively. But it's super important that it be done right away. So sooner is better, and the absolute limit is 72 hours. So it's important to take action if that happens, and you can give us a call or one of the other clinics that does what we call PEP or NPEP, and get started on medication right away.
By the way, I failed to mention that you're the chief of the Division of Infectious Diseases. And my dad was actually a pathologist at University of Miami for the longest time, 45 years plus.
That's great.
He actually worked with Margaret Fishel and Dickinson and several of the other folks. And
Who are
actually
here. Yes.
right. And actually dealt with HIV and AIDS because his specialty was renal failure. So he had a lot of kidney and other issues come his way. So I just have the utmost respect for your division, for what you do. You have such a long history of excellence, and just talking about these things and making sure the community is aware of something like post-exposure treatment is really important, because I'm sure many people are just not aware.
Yeah, we find that people are oftentimes surprised or didn't know that that was something that was available to them. And to be honest, it hasn't always been the easiest to get. There's that time crunch. And oftentimes really people are emotionally stressed out at that during that time. So, it takes some knowledge ahead of time about what to do and when, I think, to be able to act at that moment and get it done. But it's definitely worth it.
I also want to make sure that we do give the contact information. So maybe if you have a phone number that you can kind of.
Sure. Yeah. So our clinic phone number is 305-243-2584. So 243-2584. And that's probably the best way to get in touch. We also have by email, we have mobile prep at miami.edu. So mobile and then PREP at miami.edu is another way if you want to shoot an email, and then we'll give you a call back or get in touch that way. And you can also, we're on Instagram at mobile prep. And on Instagram, the schedule is posted as well for our mobile. So if people would like to come and visit us in the mobile, see what we do, and partake in any of our services, which includes also HIV testing, PEP, PrEP, and STI testing and treatment. And we're happy to come and they can talk with us and find out what we're all about.
That's fantastic. There's a lot being said right now also about the injection. Maybe you can explain a little bit about that.
Sure. So it is very exciting. There is a drug that is being reviewed by the FDA right now for injectable PrEP, which is cabotegravir. Cabotegravir is part of the combination of injectables that was approved for HIV treatment. So that's already being done in the clinics. For prevention, it's not yet approved. We're expecting, though, that maybe in January, as soon as January, we may hear something from the FDA about that drug. And it looks like right now it would be an every 2-month injection for PrEP. And in studies, it looks really fantastic.
That's
seems
great.
to be just as effective, or in some even more effective, probably because there's no issue with people forgetting to take it.
Yeah.
So yeah, really promising. There's also studies going on right now, and we have them here at the university as well. We're recruiting people for studies actually that are looking at long-acting PrEP formulations, including one that is 1 pill once a month. So still a pill format, but only taking it once a month.
And for those people who are under treatment, how long is it for the injectable instead of having to take that daily pill or whatever pills they're taking?
Yeah, so right now for treatment, the injectable is every month. That may change. It's a little bit less frequent for prevention, probably, but there is some possibility in the future that will be lengthened a little bit for treatment, for HIV treatment. But for prevention, it's likely to be every 2 months.
Okay.
Yeah. And then one of the other, and another drug that is being studied right now for PrEP would actually be every 6 months. So again, we're doing a clinical trial right now. So that's still in trials. We'll have to see if it works as well as the oral pills that we have now, which are currently the only FDA approved PrEP medication.
Oh, that's
Lots
great.
of things on the horizon. So I think it's really exciting looking forward.
Yeah.
World AIDS Day is for looking back, but also looking forward, right? So I think there are going to be a lot of options for PrEP, and I think that will also help us with stigma. For example, some people don't want to be taking a pill every day, or just don't want the reminder, having to take a hassle of having to take a pill every day. So I think that when we're able to offer more options, it's going to make it a lot more appealing for more folks.
And doctor, one of the things I'm curious about is is there an association, for example, with drugs and drug taking and HIV exposure, HIV prevention? I know that in the community, a lot of times there's a lot of crystal meth use, and it seems like there are some drugs that open the entry for that virus or any sexually transmitted disease. I was wondering if your research includes looking at that. I always see a lot of funding for PrEP and a lot of drugs funded, but I rarely see any discussion about things that bring people there.
Yeah, no, that's a really important point. So I think drug use is something that intersects with HIV in a lot of ways. So when you're talking about crystal meth or other, stimulant drugs, a lot of it is how it changes behavior. And we have researchers that we're working with here too, who are studying how best to get people who are using drugs to also use prevention strategies along with it, because we do know that using crystal meth definitely increases sexual risk for HIV, just because the behavior changes that go along with it. And of course, for injection drugs, there's a more direct link, because that is a way that HIV can be transmitted as well. We work very closely with our syringe exchange program here, the Idea Exchange,
Yeah, they're great.
They're wonderful. And they've been really, passionate about innovating around how to get HIV prevention strategies to people who inject drugs, of course, through syringe exchange, which is a really important and powerful option, as well as through PrEP and other strategies.
I know that Dr. Hansel Tukes and Emmy Martinez and those folks are always out there with needle exchange, and that's so important. A lot of folks don't know that Miami, actually, the original transmission here was through drug use and needle exposure at the very, very beginning of the crisis, and it was different than in other communities like San Francisco or New York. So I always think people forget that HIV can be transmitted just through the needle. And
yeah. I mean, right. So we know in Miami, it's about less than 10% right now that are transmitted through needle use, but that's still a really important group of folks to reach. And I think that oftentimes we need to remember that we need different ways to reach out to different groups who might be at risk for HIV. So the Idea Exchange is doing amazing work.
And really, I was wondering also, doctor, if there's some things that are kind of unique to Miami-Dade where you're trying to do this kind of work because we are so diverse.
Yeah, I mean, so what we've seen with our mobile clinic is that we go to 5 communities, and those are 5 extremely distinct communities. Each one really is its own world in a lot of ways. And we really need to kind of touch base with communities about what are the specific needs for that area, what's the best way to reach out and get information out, how do they like to have services provided, what time of day, should it be packaged with other things that are needed in that community, rather than just standalone HIV/AIDS services. Best ways to overcome stigma, which is pervasive, but also can present itself in different ways in different communities. So we found that it's really, Miami-Dade, one of the things I love about it is such a patchwork of really different communities and diverse communities that each have their own, nuance and really can't all be approached with a one size fit all.
And how are we doing overall? I know recently it was said that we were the fastest growing incidence of HIV exposure. Is that still the case? What do the numbers look like here?
Unfortunately, it is still the case that we have the highest rate of new HIV infections in the country. And
Wow.
Florida in general has a number of the top 10. So we're, as a state, we're not doing great. Um, I think that there's a lot of reasons for that. You know, it's hard to summarize in a quick summary, right? We also have a lot of people who are coming to Miami all the time from all over the United States and all over the world. And so it's very important that we get this information out as you are doing, so that people know what they can do to protect themselves, and that they're also aware of this, right? So some
Yeah.
people will come here from somewhere else where there may be much less HIV and not realize that they've arrived in the place that is really an epicenter of the epidemic.
Are there
So
any trends that we should be aware of in those numbers, like among older populations or younger populations? Where are the increases coming from? Are they more minorities or marginalized communities, or is it across the board?
yeah, I mean, so we're not seeing increases. What we're seeing is really a lack of decrease, right? So with all of the tools that you and I have been talking about, a lot
Yeah.
of places are seeing decreases in HIV incidents. And we really haven't seen substantial decreases. Still, HIV absolutely hits communities of color harder, and in the among Black men, this is an epidemic that's completely out of proportion and needs to be addressed. But also in the Latino community is also overrepresented. So I
And do
think
you think that comes with the stigma? I mean, is it because in those communities there's more stigma about being gay or trans or anything? Not that that's particular to groups, but instead the behavior that they express or the risk that they might put themselves in.
well, stigma is never helpful, right? I mean, and I think it is pervasive. So, as we were saying, the way that stigma shows itself can be different from group to group. But I think, unfortunately, we're still dealing with a situation where it is pervasive and it prevents people from accessing services or from taking prevention measures sometimes. So, yes, absolutely, that's part of it. I also think that we can do better. And this is one of the things we really are passionate about and work hard on in trying to make things very available. So, remembering that prevention isn't the top of anybody's brain most of the time. I mean,
Right.
these are people who are healthy. They're doing other things. They're working. Like we have to make it incredibly easy for people to access prevention strategies so that they don't have to go out of their way. It doesn't cost a lot of money or cost a lot of time, because many people can't afford time or money
Sure.
to do something that's preventative. So I think, we need to be realistic about offering things in a way that's easy and convenient, and it makes it really simple for folks to access,
And free of shame and free of stigma and just
as
kind of
much as
like
possible. Yes, absolutely, 100%. And I think that takes resources. That is not always. We could. I think we could do better with that.
no, for sure, for sure. Let me ask you, doctor, if you had a magic wand and you could change one thing in the landscape of HIV and AIDS, what would that be?
Yeah, I mean, I would just want to use my magic wand to have everyone instantly know all of the options that are available. I think we still struggle to spread the word sometimes, and that's why I appreciate so much what you're doing and what others in communication are doing. The communication is absolutely our best tool. That and if I could make stigma go away, I would absolutely do that, as well. But we need to get the word out. Many folks still don't either know about the tools that we have today or know that they are truly available to them. They are really available to everyone now.
I really enjoy seeing a lot of the stuff that comes out on social media, which I think is really, really good. And I'm happy that your team is really embracing all the strategies available to try to get to different people, and hopefully in all the different languages, whether it's, Spanish, Creole, or anything else. But I think, like you said, it's really being able to reach those communities.
Mhm. Yeah, absolutely. Yeah.
And so before we wrap up on World AIDS Day, which is tomorrow, December 1st, I just wanted you to repeat the contact number to make sure everyone has the number as well as the website or the email.
Yeah. So it's 305-243-2584. That's the phone number. And then the email is mobileprep@miami.edu. And again, you can also find us on Instagram at mobileprep. And that also repeatedly has all of our contact information if that's the easiest thing to remember and to find.
Dr. Susanne Doblecke-Lewis, what a pleasure. Thank you so much for your time. I'm sure you have a million things to do, so your time is precious. Thanks for spending it with us, and look forward to doing this again.
It was my pleasure. Thank you so much, Damien.
Bye-bye. Have a great day.
You too. Bye.
And thank you for joining.